Hello, and welcome to Pediatric Pharmacy Association's presentation over neonatal opioid withdrawal syndrome. My name is Jenny Matthew, and I'm a clinical NICU and women's health pharmacist at Hillcrest Medical Center in Tulsa, Oklahoma. Before we begin, I would like to say I have no conflicts of interest to disclose. During this presentation, we will review what features a neonate may present with during withdrawal and how we can evaluate severity of those symptoms. We will review the epidemiology and risk factors affecting pregnant women that can lead to NOWS. And lastly, we will focus on different options and steps the medical team can do to manage opioid withdrawal in neonates. This can be broken down into three main categories: non-pharmacological, alternative, and pharmacological treatment. Neonatal opioid syndrome was previously referred to as neonatal abstinence syndrome. In practice, you may hear it referred to as NOWS or NAS interchangeably. Any medication that can cause physiological dependence can cause an infant to present with withdrawal. However, NOWS, as the acronym suggests, is specific to opioids only. Diagnoses for treatment still looks at opiates specifically, even if a neonate is withdrawing from other medications. Opioid use over the past few years have increased immensely, with almost a third of all users being female. In 2007, almost 1 in 4 women were prescribed opioids during pregnancy. This has led to a surge in NICU admissions for withdrawal. It has increased from 7 per 1,000 cases to 27 per 1,000 cases, almost a four-fold increase. When looking at why an infant experiences withdrawal, several mechanisms have been proposed. It could be related to solely one theory, where all proposed theories could play a role in causing withdrawal. Although there is not a defined mechanism that causes withdrawal, we do know that there are several different factors that can increase the likelihood of neonatal opioid withdrawal. Infants exposed to opioids with a long half-life compared to opioids with a shorter half-life will have stronger withdrawal effects. It is the same with polysubstance abuse and extended duration of opioid use. Gestational age at the time of birth also needs to be considered. Term infants, so 37 weeks and greater, are much more neurologically developed compared to preterm infants less than 30 weeks. Therefore, term infants are likely to have more severe symptoms compared to preterm infants. So once we have a patient who is born and at risk for withdrawal, what should we expect? Signs of withdrawal can be seen as soon as 24 hours after birth or be delayed and seen as late as 7 days. Most children will present with manifestations around 48-hour mark. As we touched on a previous slide, the more preterm an infant is, the symptoms may be few and they are more likely to recover quickly. With withdrawal, there are many ways it can present. It is not uncommon to see manifestations such as high-pitched crying, irritability, sleep deprivation, tachypnea, and loose stools in most neonatal withdrawing infants. Tremors and seizures are rare and are seen with severe withdrawal cases or if withdrawal is left untreated. Indications for neonatal drug testing. If mother-baby presents with limited to no prenatal care, suspected abruption, preterm labor, neurological complications, growth restrictions, or if the child is acting abnormal that is consistent with withdrawal, it is imperative to consider testing for opioids and other possible drugs as part of the infant's workup. The main indication for neonatal testing is maternal drug use. There will be instances when a mother or baby may deny opioid or other medication use for whatever reason. It is important to use medical judgment and to decide if maternal and neonatal drug screen should be collected. This presentation focuses on opioids specifically, but drug testing applies to other medications or substances that can put a child in an unsafe environment down the road. In order to diagnose an infant with NOWS, drug testing needs to confirm we have a baby withdrawing from some form of an opioid. There are 4 options for neonatal drug testing: hair, urine, meconium, and umbilical cord. Please note, many different medications can cause false positives in drug testing, such as ranitidine and diphenhydramine. Let's look at hair testing. Hair testing will give you a fairly long window of data, about 90 days worth. It is less sensitive than urine and meconium for drug detection, and there is not routine use in neonates. Although urine testing is common and fairly easy to collect in adults, it can be somewhat of a challenge in neonates. Neonatal urine sample will give you more recent information on which opioids are present in the neonate system. However, if an infant urinates and the initial sample is not collected, levels may be too low to detect. Meconium is the first stool an infant produces. Compared to urine and hair, meconium drug testing gives an even longer window of information. Drugs accumulate in the meconium and can be detected as early as 20 weeks gestational age. There are some pitfalls to meconium testing. For instance, if there is not enough specimen collected, they can't test it properly. Just like with urine, once a patient has passed meconium, whether it is in utero or after birth, stool samples may produce false negatives due to low drug concentration. For this type of test, after birth, 6 inches of umbilical cord tissue is collected. Cord tissue will have opioids or other substances evenly dispersed through the tissue, unlike in meconium. In addition, a neonate may not pass meconium immediately after birth and can lead to delays in testing, whereas the cord can be collected immediately for evaluation. The biggest downside to cord testing is if the cord is unavailable due to the cord being disposed of prior to hospital arrival. Over time, different types of NOWS evaluation and assessment tools have been developed. But for many years, the Finnegan Neonatal Abstinence Scoring System, or the modified FNAS, has been the go-to for most facilities. However, a new approach, the ESC model, is starting to be used more and more. Looking at the modified FNAS scoring tool, it is extensive and very detailed. Neonates are scored every 3 to 4 hours to assess for signs and symptoms of withdrawal. Although the modified FNAS scoring tool gives you a good idea of what manifestations of withdrawal may be present, there are a few setbacks. The FNAS scoring can be very subjective and varies between evaluators. For instance, what one nurse considers high-pitched crying may not be the same for another nurse. This leads to variability in scoring and can make it difficult to determine how an infant is progressing. Education is key to reduce subjectivity, but with nursing turnovers, floating nurses, and contract nurses coming in and out, keeping up with education may be somewhat difficult. In addition, certain assessments, such as sweating, moral reflexes, and excoriation, requires disturbing the infant, which may prevent them from sleeping and becoming more irritable. Now that we have reviewed the Finnegan neonatal abstinence scoring and the modified version, let's take a closer look at this new approach. The Eat, Sleep, Console model was developed at Yale University School of Medicine and had a much more simplified way of evaluating NOWS compared to the modified FNAS. Grossman and team conducted this study, a novel approach to assessing infants with neonatal abstinence syndrome, to compare the Eat, Sleep, and Console approach to the FNAS scoring tool. It is a retrospective study comparing if treatment decisions changed or was similar between the two different approaches. If you recall, Finnegan scoring can be very subjective and rather lengthy to complete. But if you look at the Eat, Sleep, and Console model, it is simple yes or no questions. It decreases subjectivity and allows easy assessment without potentially disturbing the infant. Looking at the three main areas, we are evaluating if an infant is able to eat 1 ounce or more, sleep an hour or longer, and be consoled within 10 minutes or less. Here is an example diagram of the Eat, Sleep, Console assessment model with a few additional components tied into it. If we look at the far left side, if an infant is able to eat, sleep, and console with no issues, they are considered to be well managed. However, if an infant is not doing well in one or more areas, then non-pharmacological therapy should be optimized. A few examples listed are low stimulation environment, feeding on demand, swaddling, holding, and skin to skin. Afterwards, if a patient is still having issues with eating, sleeping, or consolability, pharmacological therapy should be initiated. This new shift in NOWS management puts a stronger emphasis on non-pharmacological care and focuses on the mother-baby dyad. Going back to the initial study conducted by Grossman et al., infants born at greater than or equal to 35 weeks gestational age with prenatal exposure were evaluated from March 2014 to August of 2015. Since it was a retrospective study, they used administrative codes for NAS and prenatal opioid withdrawal. Primary outcomes looked at the proportion of patients started on morphine therapy by using the ESC approach. Secondary outcomes was the proportion of days that each approach recommended a specific pharmacological management, such as no morphine, increased morphine, decreased, or continue at the same dose. They also looked at the number of incidences when the ESC approach and the FNAS approach differed in their recommendation for morphine therapy. Looking at the results of this study, prenatally 80% of infants were exposed to methadone, 14% were exposed to buprenorphine, and 6% were exposed to short-acting opioids. The ESC approach resulted in morphine initiation for 6 infants compared to the 31 infants who would have had the morphine initiated using the Finnegan approach. Morphine was initiated or increased on 8 patient days using the ESC approach, compared to the 76 patient days that morphine would have been initiated or increased using the Finnegan approach. This study demonstrated a decrease in opioid-exposed infants treated with morphine from 46% to 27%, as well as a reduction in average length of stay from 16.9 to 12.3 days in infants treated with morphine. The ESC approach looks to shift the goal from reducing withdrawal signs at the expense of adding more morphine and other medications to a focused approach aimed at overall well-being of an infant by empowering the families to be more hands-on. In addition, keeping mothers and babies together has shown to enhance a child's cognitive development. Proxy Finnegan component scores for Eat, Sleep, Console in a cohort of opioid-exposed neonates. This is a study published in 2020. It retrospectively compared the sensitivity and specificity of Finnegan scoring and ESC elements using a subset of components of the Finnegan scoring as a proxy for the ESC model. The purpose of the study was to see if cases requiring pharmacological treatment defined by modified Finnegan scoring would have been missed if the ESC assessment alone was used. NAS scores were assigned and recorded by nursing staff into the electronic medical record every 4 hours for a minimum of 5 to 7 days per hospital protocol and was continued throughout the infant's entire hospitalization. Nurses recorded the individual component scores, and the total Finnegan score was calculated by the EMR. All components and total scores for every infant in the study were extracted from the EMR. Infants with 3 consecutive scores greater than or equal to 8, or 2 consecutive scores greater than or equal to 12, were clinically assessed for pharmacological treatment. If indicated, pharmacological treatment was initiated in the NICU for infants after the assessment by the attending neonatologist. Please note that not all infants who met the Finnegan scoring threshold received pharmacological treatment. Unlike the previous study that used yes and no, this study uses negative to indicate no issues in the assessment subset and positive to indicate signs of withdrawal in the ESE subset. In Finnegan scoring, poor feeding score is either a 0 or a 2. Infants scoring 0 for poor feeding were considered eat negative to indicate eating normally. Those scoring a 2 on the Finnegan scoring were designated as eat positive. The Finnegan scoring for sleep has 4 different sleep levels. If an infant is sleeping less than 1 hour after feeds, it is a score of 3. If they are sleeping less than 2 hours after feeding, they are given a score of 2, and infants sleeping less than 3 hours after feeding are given a score of 1. If an infant is able to sleep for more than 3 hours after feeding, a score of 0 is assigned. For the ESE protocol assessment question, can an infant sleep more than 1 hour after feeding? The Finnegan score of 3 for sleep was the ESE proxy chosen. Therefore, infants scoring 3 were designated as sleep positive. Infants scoring 0, 1, or 2 for sleep in the Finnegan scoring were considered sleep negative. The Finnegan variable for cry is the closest proxy to the ESE variable for consolability. The Finnegan score for cry has 3 different levels. Normal or no cry is a score of 0. Excessive high-pitched cry is a score of 2, and continuous high-pitched cry is a score of 3. For the ESE protocol assessment question, can the infant be consoled within 10 minutes? The Finnegan score of 2 or 3 for cry was considered the equivalent of the ESE protocol parameter and thus were designated as consoled positive. Infants scoring a score of 0 for cry were considered consoled negative. According to the ESE protocol assessment guidelines, infants are eligible for pharmacological intervention if one of the 3 parameters remain positive. This also takes into consideration if it remains positive after non-pharmacological therapy is maximized. Infants were designated as ESE proxy negative if they were eat negative, sleep negative, and console negative, and these infants would not require pharmacological treatment. Because of the retrospective nature of the study and the absence of non-pharmacological intervention data, we designated infants as ESE proxy positive if they were eat positive, sleep positive, or console positive more than once in the Finnegan data to correlate with the clinical protocol of first implementing non-pharmacological treatment. These infants would have met the criteria for pharmacological treatment in our ESE protocol, assuming non-pharmacological treatment had been maximized. From February 2013 to August 2016, a total of 480 infants were opioid exposed and had Finnegan scoring. 423 of these met inclusion criteria by gestational age. The majority of infants were delivered vaginally. The most common opioid exposure was buprenorphine, and a majority of these infants had pharmacologic co-exposures. Tobacco was the most common co-exposure. For the cohort as a whole, 33,115 Finnegan total scores were reported over 921 days of observation. Although 256 infants met the Finnegan criteria for pharmacological treatment, only 165 of these infants were true positives and treated pharmacologically. This data was used to calculate sensitivity and specificity. So quick refresher on some of these definitions. Sensitivity is the ability of a test to correctly identify patients with the disease. Specificity is the ability of a test to correctly identify people without a disease. A positive predictive value is the probability that a patient with a positive test result actually has the disease. And a negative predictive value is the probability that a person with a negative test result is truly free from the disease. So in total, 9 infants did not meet the Finnegan screening threshold, yet received pharmacological treatment. An additional 91 infants scored above the Finnegan screening threshold but were not treated, and 158 were untreated and scored below the threshold. Both tests have similar sensitivity for detection of the disease. The ESC protocol had 40.2% specificity for infants requiring intervention compared to that of the full Finnegan scoring system of 63.5%. We have discussed that non-pharmacological treatment options and what is referred to as alternative or adjunctive treatment options should be optimized before going to pharmacological treatment. However, you may be asking what is considered non-pharmacological treatment and alternative treatment. For non-pharmacological treatment, there are a lot of little things that can be done to make a neonate as comfortable as possible. Some of these, such as pacifier use, swaddling, breastfeeding, are all options that are presented to healthy newborns because they have shown to help soothe a newborn regardless of withdrawal. So it makes sense to make sure to focus on those things for children withdrawing as well. I'll let you read through most of them, but I would like to touch that with the new ESC approach, family involvement is very important. Instead of separating parents from the child, parents rooming in, skin to skin, holding and direct breastfeeding are all strongly encouraged when able to do so. Unfortunately, there may be instances when an infant may need NICU care or Child Protective Services may not allow the family to be involved. Volunteer cuddler programs are available at facilities to help focus on holding or gently rocking withdrawing infants. Massage therapy, foot or auricular acupressure, Reiki, laser acupuncture, aromatherapy, and music therapy may help soothe and console infants. They may be able to reduce length of stay and medication exposure when used in conjunction with non-pharmacological and pharmacological therapy. As pointed out in Neonatal Abstinence Syndrome Management, a review of recent evidence, while generally low risk, such interventions do require staff time and attention for implementation, and as such, a systemic evaluation of specific non-pharmacological and alternative therapies would assist clinicians in directing time and effort toward high-yield intervention while decreasing efforts at low-yield efforts. Moving on to pharmacological interventions. The two main assessment tools used at most institutions are the modified FNAS or the ESC model. For the modified FNAS, 2 consecutive scores greater than or equal to 12 or 3 consecutive scores greater than or equal to 8 are indicative of treatment. For the ESC approach, treatment should be initiated if an infant is unable to meet expectations in one or more area after maximizing non-pharmacological therapy. First-line agents for therapy include morphine, methadone, and buprenorphine. Second-line agents for withdrawal are phenobarbital and clonidine. The second-line agents can also be considered symptom maskers. These agents do not directly help with opioid withdrawal, but can be useful if the first-line therapy alone isn't capturing the infant. Let's start with morphine. Historically, morphine was considered the drug of choice before methadone and buprenorphine was evaluated as options for NOWS treatment. It is a short-acting opioid with a duration of about 3 to 5 hours. When treating neonates with opioids, respiratory depression should be monitored. Patients may also have some abdominal distension and loss of bowel sounds. Recommended dosing for withdrawal is starting at 0.03 to 0.1 milligrams per kilogram per dose every 3 to 4 hours, with a max dose of 0.2 milligrams per kilogram. If a patient is not responding well to the initial dose of morphine, the dose can be titrated up. If a neonate is receiving around-the-clock morphine every 3 to 4 hours, a slow taper down is necessary. Studies suggest 10 to 25% wean of the original dose per each wean at a frequency of every 48 hours. Keep in mind that weaning information is a suggestion and not an absolute of how you should wean. Neonatal withdrawal assessment should be the driving force to determine if an infant should be weaned. Next, we have methadone. It is a long-acting analgesic, but peak levels can be achieved within 2 to 4 hours. In children, half-life can vary from 4 hours to as long as 62 hours. Compared to morphine, methadone may decrease length of stay, and due to how methadone is metabolized, we need to be cautious of drug interactions. Methadone is a synthetic mu-opioid receptor agonist. The dose recommended in column 3 is a starting dose recommendation. Patients can be on methadone at a frequency of every 12 or 24 hours, in addition to the every 6-hour recommendation. There are weaning protocols created that recommend set dose weans instead of a percentage wean. But just like with morphine, neonatal assessment in response to methadone should be the guiding tool for weaning rather than following a strict weaning schedule. Buprenorphine is the third recommended agent that can be used. Buprenorphine for injection is mixed with ethanol and simple syrup for sublingual use. Even though simple syrup is added, this elixir contains 30% alcohol, and thus palatability is low. Buprenorphine is a partial mu-opioid receptor agonist. Starting dose recommendation is 5.3 micrograms per kilogram every 8 hours, and the dose can be increased by 25% with max dose of 60 micrograms per kilogram per day, or 20 micrograms per kilogram per dose. A recommended weaning suggestion is to wean by 10% until dose is at 10% of the initial dose and then discontinue. Phenobarbital is considered a second line or an adjunctive treatment for NOWS since it does not act on opioid receptors. It can be beneficial for children withdrawing from polysubstance abuse, but please note, phenobarbital can cause heavy sedation, and this can interfere with feeding. Phenobarbital is available commercially as a solution or elixir containing 13.5 and 15% alcohol respectively. In addition, they contain benzyl alcohol and propylene glycol as preservatives. Compounded phenobarbital without preservatives and alcohol can be made. Phenobarbital is a gamma-aminobutyric acid agonist with a long half-life. It can be used in conjunction with morphine as shown to decrease length of stay and overall morphine exposure. However, even though phenobarbital can potentially be titrated every 48 hours based on withdrawal assessment, a study conducted in 2021 by Merhar showed that patients who received morphine and phenobarbital, 78 of those patients were discharged home on phenobarbital, but morphine was stopped. Lastly, we have clonidine. Just like phenobarbital, clonidine in conjunction with morphine can reduce overall neonatal exposure to morphine and hospital stay. Clonidine adverse drug events documented in neonates include hypotension, bradycardia, and possible rebound hypertension. Compared to phenobarbital and the concern for long-term neurodevelopmental effects, clonidine's adverse drug event profile is fairly mild. Although morphine plus phenobarbital compared to morphine plus clonidine has shown to be more effective in reducing hospital stay and morphine exposure, it is at the expense of potential neurological deficits due to the phenobarbital. Therefore, there is no consensus if clonidine or phenobarbital should be used first as a second-line agent. Clonidine is an alpha adrenergic blocker with doses at 0.5 to 1.5 microgram per kilogram per dose every 4 to 6 hours. Patients should be off of morphine before clonidine weaning is initiated. Clonidine should be discontinued prior to hospital discharge. Here we have pharmacological dosing summary. Titrations and weanings listed are meant to help guide providers. Neonatal withdrawal assessment, whether it is modified FNAS or ESC, should determine if an infant needs changes in medication dose. Let's look at this patient case for TJ. TJ is a term male born at 38 weeks and 2 days and was admitted to newborn nursery 3 days ago. He was born via vaginal delivery without any complications. When we look at maternal history, she is 24 years old, G3P1 and now a G3P2. She had late prenatal care and has gestational diabetes and hypertension. She reports a history of meth use, but currently is on Suboxone for the last 6 months. She does vape daily and occasionally uses marijuana when she can't deal with it anymore. Urine drug screen is collected on the mother and TJ. Question 1. Which of the following are signs and symptoms of NOWS TJ may exhibit? A. Tachypnea, hypertension, diarrhea, excessive sleeping. B. Tachypnea, diarrhea, sleep deprivation, weight loss. C. Excessive sucking, hypotonic tone, excessive sleeping, sweating. Or D. Bradycardia, high-pitched cry, hyperthermia, and weight loss. B is correct. Tachypnea, diarrhea, sleep deprivation, and weight loss. A and C are incorrect. Patients who are going through withdrawal have sleep deprivation and not excessive sleeping. D is also incorrect because withdrawal presents with tachycardia and not bradycardia. In addition to tachypnea, diarrhea, sleep deprivation, and weight loss, patients can also present with high-pitched cry, hyperirritability, hypertension, tachycardia, vomiting, sneezing, excessive sucking, poor or excessive feeding, sweating, hypothermia, hypertonia, and tremors. So continuing with TJ, on day of life 3, TJ is not sleeping well and having more watery stools. He is transferred to the NICU for closer monitoring. Today, he is more irritable, unable to sleep or console himself. Maternal urine drug screen is positive for buprenorphine and norbuprenorphine, a metabolite of buprenorphine. Provider requests non-pharmacological measures to be initiated and modified FNAS scoring. TJ scores are 6, 9, 9, 10, 6, 8, and 5. So, should pharmacological treatment be initiated for TJ, and if so, which medication should be used first? Yes, TJ has received 3 scores greater than or equal to 8. Initiate methadone at 0.05 milligrams per kilogram per dose every 6 to 24 hours. B. Yes, TJ has received 3 scores greater than or equal to 8. Initiate clonidine 0.5 micrograms per kilogram every 4 to 6 hours. C. Yes, TJ has received 3 scores greater than or equal to 8 and initiate morphine at 0.03 milligrams per kilogram per dose every 3 to 6 hours. D. No, TJ has not received 2 scores greater than 12 and therefore does not meet requirements for pharmacological treatment. Or E. A and C are correct. Looking at TJ's modified FNAS scores of 6, 9, 9, 10, 6, 8, and 5, he has had 3 consecutive scores greater than and equal to 8, and therefore should have pharmacological treatment started. Therefore, D is incorrect. Morphine, methadone, and buprenorphine are considered first-line agents, and phenobarb and clonidine are used as second-line agents as adjunctive therapy. So B is incorrect. Therefore, A and C are the correct answers. Let's look at a different patient, patient BR. BR was born at 2,700 grams, 35 weeks and 5 days, and he was admitted to the NICU for temperature instability and mild respiratory distress. BR was initially placed in a radiant warmer and started on CPAP at 21%. Due to breech presentation, a C-section was conducted at time of delivery. When we look at maternal history, mother is a 31-year-old whose G5P0, now G5P1. She had regular office visits, and overall her prenatal labs were unremarkable. She does have a history of chronic opioid use secondary to a motor vehicle accident that occurred at the age of 22. She's on Percocet 10 milligrams 4 times a day as needed. While in the NICU, BR is quickly weaned off of CPAP and is on room air within 6 hours of birth. Eat, sleep, and console assessment and non-pharmacological measures are initiated. BR's mother is worried she will not be able to direct breastfeed while BR is withdrawing. Maternal urine drug screen is positive for oxycodone. Which of the following is the best response? A. No, BR cannot directly breastfeed at this time because it will increase stimulation. B. No, there will be too much oxycodone in the breast milk and can cause harm to BR. C. Yes, direct breastfeeding will mean he will not require any pharmacological treatment. Or D. Yes, direct breastfeeding as well as skin to skin will help BR with withdrawal symptoms. The correct answer is D. Yes, direct breastfeeding as well as skin to skin will help BR with withdrawal symptoms. Direct breastfeeding and skin to skin are useful non-pharmacological measures that can help console an infant and focus on the mother-baby dyad. There is minute concentrations of opioids present in breast milk, but it is not enough to cause harm. Regarding letter C, non-pharmacological measures such as breastfeeding can reduce pharmacological treatment, but it does not mean that the small amount present is enough to prevent pharmacological treatment from being initiated. Okay, on to question number 4. Which of the following are additional non-pharmacological measures that BR's mother can do to help console and soothe BR? A. Unswaddling the infant to prevent sweatiness. B. Increasing cluster care from every 3 to 4 hours to every 2 hours. C. Frequent diaper changes with barrier cream to prevent diaper dermatitis. Or D. Playing loud music to prevent outside distractions. The correct answer is C. Frequent diaper changes with barrier cream to prevent diaper dermatitis. Regarding answer choice A, we want to keep the infant swaddled. They're used to having barriers in utero, and keeping them unswaddled can increase irritability. Answer choice B, cluster care is a great option to prevent disturbing the infant and causing overstimulation. However, more frequent cluster care at every 2 hours can have the opposite effect by waking up the infant more. Lastly, D is incorrect due to similar reasons as B. Loud noises can be overstimulating and worsen withdrawal symptoms. Let's look at question number 5. On day of life 4, BR's nurse reports the infant is eating well and is consolable when held. However, based on Eat, Sleep, Console model, BR has barely slept all day despite maximizing non-pharmacological options. Which of the following is the best course of action? A. Initiate phenobarbital 5 milligrams daily to help with insomnia. B. Give a one-time dose of morphine dosed at 0.4 milligrams per kilogram. C. Reassess at next hands-on to determine if BR qualifies for treatment. Or D. Start scheduled morphine dose at 0.4 milligrams per kilogram every 3 hours. Based on the Eat, Sleep, Console model, BR should be treated pharmacologically because he is positive for one or more components. Therefore, answer choice C is incorrect. Answer choice A is incorrect because phenobarbital is considered second line. It may allow the infant to sleep due to its sedating effects, but it is only masking the infant's symptoms and not actually treating withdrawal. If we look at answer choice D, the dose is appropriate, but when using the Eat, Sleep, Console approach, we do not want to automatically begin scheduled morphine. Every round of hands-on, BR should be assessed to see if pharmacological treatment is needed. To recap, NOWS clinical manifestations can be seen as early as 24 hours or can be delayed up to 7 days after birth. Opioids are the most common medication to cause withdrawal in infants. Other substances can lead to withdrawal, however, withdrawal treatment is based on opioid exposure alone. Keep in mind, term infants are more likely to present with more severe symptoms than preterm infants less than 30 weeks gestational age. The duration and amount of opioid exposure increases the likelihood of infants presenting with worse manifestations. Diagnosis is based on maternal history and neonatal drug testing. If there is concern an infant may be withdrawing, or maternal concern despite denying medication use, drug testing should be collected. FNAS and modified FNAS has been a standard for many years. However, it can be very subjective and thus extensive education is key. With the new ESC model, the focus shifts to maximizing non-pharmacological and/or alternative therapy, as well as promoting the mother-infant dyad. Pharmacological agents can and should be used if an infant is showing signs of withdrawal. Lastly, when pharmacological agents are used, morphine, methadone, and buprenorphine are all good options to begin with. Phenobarbital and clonidine are recommended as second-line agents to be used in conjunction to first-line options. Thank you for listening to this presentation over neonatal opioid withdrawal syndrome.